Good morning, everyone. My topic is biometric accuracy of refractive outcomes using BARRETT Universal 2 formula in holiday schema. The most important factor affecting the refractive outcome of a cataract surgery is the IOL power, and hence the IOL power calculation formula. The variation in axial length of 1 millimeter can change the IOL power by 2.5 to 3 diopters. The BARRETT formula uses a theoretical model I whereby the anterior chamber depth is related to axial length and keratometry. To the best of our knowledge, no study has analyzed the accuracy of BARRETT's Universal 2 formula in all the ocular geometries described by holiday schema. Aim of the study is to analyze accuracy of refractive outcomes by BARRETT Universal 2 formula in different ocular geometries by holiday schema. Retrospective chart review of patients who underwent uneventful cataract surgery by phacoemulsification with in-the-back intraocular lens implantation was performed. The study duration was around 6 months. Inclusion criteria: patients with age-related cataracts who underwent uneventful cataract surgery within the age range of 45 to 80 and amenable to optical biometry were included. Exclusion criteria included intraoperative complications, the presence of any corneal pathology, any prior ocular surgeries, or requiring any additional surgical procedures at the time of cataract surgery, and no traumatic cataract, PPC, zonular dialysis, coloboma or hypermature cataracts were included. Methodology: ocular biometry was performed using optical biometer OA 2000 TOMI, and the surgeries were performed by a single surgeon with a 2.2 to 2.8 mm temporal clear corneal incision by phacoemulsification. The pre-op and post-op refraction and IOL power implanted and predicted refractive error for BARRETT's Universal 2 formula were noted. The sample size was divided into 9 categories based on the axial length. 21.6 to 25 mm was considered the normal, less than 21.6 as short, and more than 25 mm was considered as long axial length. White to white measurement 11 to 13 was normal, less than 11 short, and more than 13 mm was considered as large. The expected refractive error of the IOL implanted in each subgroup was compared with the mean postoperative spherical equivalent. Coming to the results, the demographic statistics: total number of patients were 663, out of which 396 were females and 266 males. The lateral 333 were right eye and 330 left eye, and the age range was 45 to 80. This is the original holiday schema. And in our study, we found that relative anterior microphthalmos and normal eyes were in higher proportion. Coming to the descriptive statistics, the axial length, the mean was 23.24 with plus or minus 0.96 standard deviation, and the mean white to white was 11.6 with plus or minus 0.5 standard deviation, and the mean AC depth was 3.4 with plus or minus 0.44 standard deviation. So we found that the AC depth was deeper in myopes as expected, and in contrary to the expectation, the AC depth in megalophthalmos was in the normal range. And coming to this analysis, the Bland-Altman plots the differences between a pair against the mean of the pair of measures, and we have plotted the mean of expected and achieved on the x-axis versus the difference between expected and achieved mean refractive spherical equivalent on the y-axis. The mean difference is only minus 0.12, and 95% of the values lie between the limits of agreement, that is the mean difference plus or minus 2 standard deviation of the mean difference. Hence, it shows that there is good results for nanophthalmos using BARRETT's Universal 2 formula. In axial myopia also, the results are similar. In relative anterior in axial hyperopia, the statistically significant systematic differences are noted, which means that both differ at least by a constant amount, and this can be corrected by adjusting the A constant or lens factor. The outcomes are more myopic than expected, hence we need to alter the A constant by the amount of mean difference. In relative anterior microphthalmos, improvement can be achieved in the outcome by adjusting the A constant to compensate for the systemic bias, but proportional differences are also present where there is at least a proportional difference between the two methods. In positive slope, there is direct correlation between the means and the difference between the means. In normal, some improvement can be achieved in the outcome by adjusting the A constant to compensate for the systemic bias, but proportional differences are present where there is at least a proportional difference between the two methods. In negative slope, there is inverse correlation between the means and the difference between the means. In the subgroup analysis for normal eye for the different IOL models, the Orolab IOL shows proportional bias with negative slope, and the Hoya IOL also shows proportional bias with negative slope. The J&J IOLs, that is the eye hands, techniques and sensors, show a systematic bias of only minus 0.08, which is clinically insignificant, and the minimal negative slope on proportional bias. The negative slope implies that if you put an IOL of plus 40 diopter of power, expected minus achieved gives a myopic result, and if you put a minus 10 diopter power, expected minus achieved is hyperopic than expected. So this information can be used to customize the outcomes close to target refraction in different ocular geometries and with different IOL models. In normal IOCare IOL in normal eyes, similar systematic and proportional differences are noted, and though the magnitude of differences is greater than for J&J IOLs. UP IOL also shows similar differences with maximum magnitude of differences. The limitations, it's not adequately powered for subgroup analysis for all holiday subtypes and for all IOL models. It's reported that newer IOL power calculation formulas have achieved better results. However, these formulas currently require third-party software or an online calculator and cannot be easily used in the general clinical setting. The BARRETT Universal 2 formula is integrated to commercially available optical biometer. Hence, it can be easily applied and contribute to reduction of refractive prediction error after cataract surgery in the general clinical setting. To conclude, the BARRETT Universal 2 formula may be regarded as a reliable formula for achieving emmetropia and reducing postoperative refractive surprises across different axial lengths. And the formula also gives constant predictable refractive outcomes despite 7 different clinically seen types of ocular geometry. And the same IOL formula, when used in different ocular geometries, gives subtle variations in the outcome, and the same type of ocular geometry, different IOL models perform differently. So we should be aware which IOL model is superior in a specific ocular geometry. Thank you. So for references.
So what is new? It's already known, isn't it?
It's already, yeah, the results are already known. What we have found is that there is like the results are myopic. There has been studies in different subgroups, but there is no proper study in all the ocular geometries.
True. I mean, lenses will keep coming, and you have to, if you keep doing, I mean, that variation is going to happen always. Okay, thank you.
Next we have Dr. Monisha Mohan, and she'll be talking on utility of plus 1.50 diopter test to identify clinically significant hyperopia in school screening programs.
So good morning everyone. So my paper is on utility of plus 1.5 diopter test to identify clinically significant hyperopia in routine school screening programs. So we know uncorrected refractive errors are the most common cause of avoidable visual impairment, and hyperopia gets considerably lesser attention than myopia. That is because the etiology is believed to be almost entirely due to genetic or hereditary factors. So it may produce a reduction in both distant and near visual acuity depending on the patient's accommodative ability. However, there is a lack of data regarding the prevalence, the test and the amount of hyperopia that actually requires spectacle prescription. So our primary objective was to investigate the utility of plus 1.5 diopter test to identify clinically significant hyperopes in school-going children. The secondary objective was to study regarding the symptomatology presented by these hyperopic children. So it was a retrospective cross-sectional study using the REACH model as a part of comprehensive school screening program. It was a 3-year data collected between July 2016 to 2019, and we had a population of 2,85,177 students who were included between the age group of 6 to 18 years. In and around Madurai district of India, all the schools willing to participate were included from the grade 1 to 12. So what is the rationale of using 1.5 diopter lenses in this test? So we know fogging is a technique to inhibit accommodation with plus lenses, and vision is blurred by creating an artificial myopia which makes accommodation worse. So in hyperopes, accommodation is necessary to produce a focused image at both distance and near. So vision improves with a plus lens in patients with hyperopia, and with emmetropic patients it reduces. So an increase in accommodation may serve to compensate at least partially as much as 1.5 diopters, which is also known as latent hyperopia. Hence the 1.5 diopter lenses were used as a screening tool. We chose a cutoff of 1.5 diopters since clinically significant hyperopia usually appears after this value, which requires spectacle prescription. So coming to the methodology, so the primary vision screening was done by trained vision screeners using the illuminated pocket vision screeners at 3 meters distance. The visual acuity cutoff which was taken was logma 0.2 or 6 by 9.5. So those students who read logma 0.2 were subjected to this 1.5 diopter test to identify hyperopes. Now those students who did not read logma 0.2 were referred for detailed evaluation directly. So the students who were subjected to this 1.5 diopter test and those students who read this logma 0.2 with these lenses were referred for detailed evaluation to rule out clinically significant hyperopia. Now those students who did not read logma 0.2 with 1.5 diopters were considered normal and inquired regarding asthenopic symptom, and also all the patients were evaluated for any abnormality such as squinting, nystagmus, amblyopia and other issues. And if any such abnormality was found, they were referred for detailed evaluation. So post that, subjective and cycloplegic refraction, anterior segment and fundus examinations were done and the best glasses were prescribed according to standard prescribing guidelines. So based on American Optometry Association, we know that hyperopic refractive error is classified into low, moderate and high. Low is 0 to +2, moderate is +2.25 to 5 and high is more than 0.25 diopters. So coming to the results, coming to the demographic details, a total of 2,87,155 students from 126 schools were taken, and there were equal proportionate between the males and the females, both 50-50% almost, and 44% belong to the rural population and 57 or 56% belong to the urban population. Coming to the prevalence of hyperopia itself, so the total number of hyperopes that were found were 1,379, that is 0.5%, and majority of these detected hyperopes belong to the age group between 9 to 15 years, and low hyperopia was the most common and comprised of 80% compared to the moderate and the high ones. So coming to the main parameter of the study, the utility of 1.5 diopter test in identifying hyperopia. So as you can see, the hyperopes that were picked up totally were 1,379, amongst which in the preliminary examination 1,007 were picked up and 255 were due to 1.5 diopter test and 117 were due to symptomatology. And similarly, the glasses that were given were predominantly from the preliminary examination itself, which was 471, and the glasses given through the 1.5 but picked up through the 1.5 diopter test and then given glasses were 62, and symptomatology were just 26. Coming to the ocular symptoms, so out of the 1,379 students, 108 of them had visual symptoms and were identified as hyperopes. 9 students had eye abnormality, which could be squinting or nystagmus, and were identified as hyperopes. So a total number of 117 students were identified from the symptoms and the eye abnormalities, and headache and eye pain were the most common symptoms presented by these patients. So to conclude, the prevalence of hyperopia itself is extremely low, that is 1,379, that is just 0.5%, and hyperopes mostly were picked up in the preliminary examination stage itself, and very few were due to 1.5 diopter test and symptomatology. So 1.5 diopter test is nothing but an additional step which could be time consuming and expensive in screening such large numbers. Hence, it's not a required step in the routine school screening programs. So coming to the strength, it was a large sample size. We had a large population, and the lower threshold of 1.5 diopters was taken as a cutoff for identifying hyperopia. Deletion of this step in routine school screening would mean time saving and lesser expenses. Emphasis may be given to the other refractive errors which are more common in school going age, and this model replicates the environment usually experienced by the children, giving realistic assessment of the vision. Coming to the limitation, our study population was aged between 5 to 15 years. Children below 5 years were not screened in whom hyperopia is more common, and few studies have compared 1.5 and +2 for ruling out clinically significant hypermetropia and concluded +2 lens as a better test to identify hyperopia. These are my references. Thank you.
Same reach data.
Reach data, but different.
So, yeah. I won't say it is. Why should we leave those 255 also is my question.
Even if you have picked up very little. But yeah, in the larger sense of allocating resources,
Yes.
probably in a community sense, probably it's not important. But if your organization is doing a limited number of schools which you cover every time,
Then
it's perfectly valid to do that. Maybe when you're looking in lakhs of children, it becomes an expensive and entry test. But if you are doing 5 schools, why should you miss that 0.4 at?
because prevalence itself is so less and we're
Yeah,
taking
I
time
agree.
to
I agree. But